And the idea is that these are health promoting strategies, whereas in the current medical model, we tend to try to manage disease. And honestly, when we're managing disease, it usually means we're sort of trying to deal with symptoms, and really we're not actually helping that person heal from the disease. We're managing it, and that's very it's a good thing to do, I guess, from a certain point of view, but from another point of view, it's dissatisfying. So the metabolic strategies, I'm trying to see if they can help people with some of these what I call lifestyle disorders. The main ones would be sort of atherosclerosis, which leads to most heart attacks and some strokes, as well as cancer and neurodegeneration. So Alzheimer's disease, Parkinson's disease, and so on. And I'm trying to see if basically the metabolic strategies have an impact on these disorders in terms of clinical symptoms, function, quality of life, and so on.
Matthew, thank you very much for being here. I see you're in the Waikato. I at one time lived there and played rugby there for Hautap. I don't know if you're familiar with Hautapu, and so I'm very familiar with. Well, I haven't been there. I was there in the early '90s, so it's good to see somebody from there again. Can you be kind enough to share your background with us?
Yeah, sure. So I'm originally Canadian, and I lived there for more or less first 25 years of my life, and did university and so on. And then I moved to Australia for 12 years and did most of my medical training there, including my neurology training, mainly in Adelaide and then Melbourne. And after that, I sort of took 3 years out. It was kind of like, I like to think of it as a self-created fellowship, because I didn't know what I wanted to specialize in when I finished all that neurology training. And so I took 3 years out, basically traveled, worked, and volunteered, actually, mainly in South America and Asia. And during that time, I thought about different ways to help people with some of these really difficult conditions that, quite frankly, I'd been very dissatisfied with in my training as to how we approach them. And it was at that point I decided to move to New Zealand. Why New Zealand? I don't know. It was a halfway point between Australia and Canada. It's kind of got the mountains, but it's got a lot of nice things, beautiful people too, really nice people here. And I've been here 6 years now, and just pursuing this research that we're probably going to talk a little bit about.
I was going to say, when I lived in New Zealand, I found the people to be absolutely wonderful. You really enjoyed my time. They're great folks, very adventurous. Obviously a very sporting community. So yeah, let's talk about the research, because I think that's super exciting what you're doing. So tell us a little bit, maybe give us a little background on the research.
Yeah, okay. So it's kind of like for the last 6 years, it's been a thing in evolution. And actually, the more research I do, the more it changes my thinking. And the more I change my thinking, it changes the research, of course. And I think that's a good sign. But basically, the research is using what I call metabolic strategies. And the main two I would consider to be those are fasting and ketogenic diets. And as you know, a ketogenic diet can be a wide variety of different ways to approach that, and fasting too. And the idea is that these are health promoting strategies, whereas in the current medical model, we tend to try to manage disease. And honestly, when we're managing disease, it usually means we're sort of trying to deal with symptoms, and really we're not actually helping that person heal from the disease. We're managing it, and that's very it's a good thing to do, I guess, from a certain point of view, but from another point of view, it's dissatisfying. So the metabolic strategies, I'm trying to see if they can help people with some of these what I call lifestyle disorders. The main ones would be sort of atherosclerosis, which leads to most heart attacks and some strokes, as well as cancer and neurodegeneration. So Alzheimer's disease, Parkinson's disease, and so on. And I'm trying to see if basically the metabolic strategies have an impact on these disorders in terms of clinical symptoms, function, quality of life, and so on. And I guess the whole goal is we can talk about ketones and ketosis and all that stuff, but I know prior speakers of yours have spoken about that. But ultimately the goal is to improve metabolic health. And I'm defining metabolic health as optimized mitochondrial function. So the mitochondria, little batteries in almost all the cells in our bodies. It's really about trying to enhance those, get them to get new ones to be formed, so mitogenesis, and get old ones to be broken down, so mitophagy, and basically have the mitochondria that you currently have functioning at optimal levels or near optimal levels. You can always get better. And does that make a difference to these disorders? So that's on a clinical level. That's the interest.
So I guess the question is, does it make a difference? I mean, intuitively, you'd assume yes, and then how do you assess it? Because you can't just. Yeah, it's hard to assess how many someone's mitochondrial. I think
Oh
outside of
yeah,
biopsy, but how do you manage this stuff?
yeah. So if this theory is correct, if this approach is correct, and it may not be, right? Every day I walk to work wondering if I'm a little bit crazy or not. Probably am, but then there will probably be a whole slew of tests that we will develop in order to assess mitochondrial function. So rather than focus on that, which is that would be a whole new field in my opinion, I'm just looking at the perspective: does this help the people with their day-to-day symptoms, quality of life, function, and so on? Do these strategies help that? So that involves clinical assessments, and we've done a randomized controlled trial in Parkinson's disease, as you probably know, and a randomized crossover trial more recently in Alzheimer's disease. And we had appropriate control groups. So in both of those, so people who stayed on still made improvements to their normal diet. And in both cases, the experimental group, the one on the ketogenic diet, did show improvements above and beyond the control group. One has to always be very skeptical, and I'm extremely skeptical of my findings. But and honestly, a lot of the reason I'm doing these, Shawn, is to discover the truth. That's the main interest. And if there's a truth that we are missing that could help a lot of people, we need to find it. So, but I think in the neurodegeneration, Alzheimer's, Parkinson's, or neurodegenerative disorders, I think it does help. I'm pretty sure it does. I've seen some pretty remarkable cases, and those are only the two trials. I have a number of other patients with other disorders who are trying these, and it's pretty encouraging. And we're currently doing a trial in cancer right now. So look, aggressive cancers, glioblastoma multiforme. So look, if it works for that, if it helps with that, this is not just a ketogenic diet we're doing for that. We're doing something way beyond that. Then you can't argue against that. If you can help people with a brain tumor that on average, kills most people within a year or two, if you can prolong their survival and quality of life and so on with a metabolic strategy, then in my opinion, you can't argue with that. It's obvious.
Yeah, and yet there will be people that argue. Clearly.
Yeah.
And I've had the opportunity to interview at least two guys, Pablo Kelly and Andrew Scarborough. Both guys are. Well, I think Andrew had an astrocytoma and Pablo had a glioblastoma, and they're both 5, 6, 7, 8 years into this and still doing basically largely in remission, which is pretty remarkable. You find, and I'm sure you're familiar with work like Dale Bredesen, who's been doing research on ketogenic diets and Alzheimer's disease, and there's quite a few people looking into it, which I think is fascinating because you'll see a convergence of findings, and all these independent researchers find the same thing, there's something there. Are you thinking that it's the ketones themselves, the beta hydroxybutyrate, that is the molecule of interest is providing the benefit, or is it the milieu that you set up? Because some people will say, well, maybe I should just add exogenous ketones, it'll make everything go away. And other people say, no, you need to fix everything else that's preventing ketosis, which might be garbage in the diet. What are your thoughts on that?
It's a really good question, Shawn. And to be quite frank, the last Metabolic Health Summit I went to in 2020 in California, I was a bit disappointed because I saw people veering off, concentrating too much on the ketones themselves. And also there are a number of products being developed around the ketones, exogenous ketones. So in my opinion, the ketones are beneficial. Sure, they are a superior energy source for brain and muscle in particular. They do have sort of a cleaner burning fuel aspect to them in that they produce fewer reactive oxygen species, and they have signaling functions, which many people are really excited about. But they are the tip of the iceberg. They are a marker of ketosis. They are a marker that you are shifting your body into this milieu, as you call it, metabolic state. And to me, it's the orchestra. There's no one particular instrument, even the ketone, that is particularly important. It's getting your body into that orchestrated, very complex metabolic state where, honestly, if we look at this from an evolutionary perspective, we're trying to resurrect the hunter-gatherer state. We're trying to resurrect the hunter state where you're sort of gone without food, your senses are sharpened, your brain is functioning better, your muscles are functioning better, because you have to hunt and find an animal and eat it. So that's what we're sort of trying to do, get people out of this metabolic, constantly fed state of 3 meals a day plus snacks and glucose everywhere. I think that's really what it is. So the ketones to me are a marker of that. And when I have my patients who do these protocols with me, I get them to measure their ketones every day at the same time. And sometimes they get frustrated that the ketones are this or that. And I say, look, the ketones are a marker. You should be a little frustrated because they're a good marker, but it's not the ketones that matter. It's the mitochondria at the end of the day. And so to me, ketosis is a marker of a state where the mitochondria are given a chance to undergo biogenesis, mitophagy, and enhance their function. Yep. So definitely the orchestra.
And I love that using that orchestra. That's a great analogy, because it's not the the lead violinist. It's the whole orchestra that makes a difference. And I'm sitting here listening to you talk about these neurodegenerative diseases, and we've got somebody in our audience right now, Kevin, who has got MS, and he is basically reversing that. He's had thoracic plaques go away by using a high-fat ketogenic carnivore cell diet. And so it's incredible to see this stuff. And like you'd mentioned, and I try to sort of get this point across quite a bit. Instead of focusing on biomarkers and symptoms when we're treating disease, we have to look at what we're actually trying to prevent. And what like I said, when we're treating diabetes, are you treating the glucose, or are you trying to prevent the retinal damage and the nephropathy and the cardiovascular disease? And I think we get lost in that, even as physicians, and it's very easy to do because things that are easy to measure. Like you said, the mitochondria are tough to measure, but that may be what we need to measure, or something to that effect. And it's tough to do that. So we draw blood because it's easy to get, and it may not be the most reliable marker that we have. It's interesting about the Parkinson's, because I've seen a few people, doing some dietary modification with Parkinson's, and they've improved their symptoms. They've gotten stronger. They're kind of non-specific towards just general health improvement, but I haven't seen like complete reduction of tremors or the rigidity, the cogwheel rigidity, the things that are hallmarks of Parkinson's. What are you finding with Parkinson's disease and diet?
Yeah, so if we look at Parkinson's specifically, that's a tough one to assess, first of all, because it's a whole body disorder. It affects certain parts of the brain, yes, but it affects the enteric nervous system, so the gut nervous system. It affects even white blood cells. They're dysfunctional in these people. What I'm finding is mitigation of most of the symptoms that affect quality of life the most, which a lot of people don't know about. So Parkinson's, because it's complex, you get the tremor, you get the slowness or the bradykinesia, you get the walking instability, and so on. But the bulk of the disorder that affects quality of life is other things. So mood, depression, anxiety, apathy. Sleep is universally disrupted in these people. So they have insomnia, and they might have a REM sleep disorder where they kick, punch out, talk in their sleep, or yell or whatever. So these are and then of course, sleep deprivation affects quality of life big time. So those things improve on a keto diet. And we saw that with the randomized control trial that we did a few years back. I've had a few patients doing it since then. Of course, these tend to be the people who stick with it longer because they're experiencing greater benefit, and they have remarkable improvement. I have one lady that comes to mind. She's just written a book on this. When I first saw her, it was a spot diagnosis, like that's Parkinson's, and she entered the trial. She was one of the participants. Now, when I Zoom her, I can't tell that she has Parkinson's. And it's not the medications, because she's taking very low doses, and sometimes she goes without. So it's the dietary changes. And I got another guy who Zoomed me. This one I can't verify from the States. He was diagnosed with Parkinson's by his neurologist in the States. He showed me his paperwork. He sent them over and stuff. And this, I don't advocate this, but he went on a 60-day fast, 60. So he was a big man with a very high body mass index. And again, his Parkinson's, he thinks it was reversed. His neurologist can't detect it now. I certainly can't detect it when I do a Zoom call. That's not the ideal way to assess this disorder, but I can. And so, I'm very skeptical. Was the original diagnosis correct? It may not have been, but I have seen some remarkable results. And that's just Parkinson's. There's a number of other disorders. I'm doing a spread shot here, trying to apply these things to a whole lot of disorders. I don't want to specialize in just one.
Yeah, and I think you should, because I think nutrition impacts, I think, just about every chronic disease there is. I mean, I don't think
100%.
I don't think that's a too much of a radical statement to say that. Dementia, in general, whether it's Alzheimer's or some of the other forms of dementia, is becoming more and more prevalent. I mean, I think that's becoming clear, and I think it mirrors our obesity, diabetes epidemic. Are you seeing? So let's talk a little about dementia. Are you seeing some improvements with that as well?
Yeah, I would say yes. So in the recent randomized controlled trial on Alzheimer's disease that we did, that was actually a crossover trial. The cognition did not improve to a statistical level, but it definitely trended upwards. And I remember this was only a 3-month dietary change. So, and these were people who are sort of approaching the moderate level of dementia. So not in a nursing home yet, but getting there. And I think that was very encouraging. In terms of other people, I've had patients with dementia disorders here and there who get benefit, their scores go up. Again, it's very difficult outside of a clinical trial to know. You really need a control group. So, and that's been some of the criticisms of Dale Bredesen's work, is he's been struggling to find a trial design that can appropriately show what he's trying to show. So, I think it does help. The thing with these metabolic strategies or lifestyle strategies in general is that they don't. A medication gets you better. It removes a symptom or masks a symptom, I should say, right away, usually within a few days. These strategies don't work in a few days. They work, the longer you do it, the better they get. So if weeks is better than days, months is better than weeks, years is better than months. I mean, I've been doing this strict for 6 years myself, and I'm noticing improvements year to year. So that is how I view it. And for dementia, I think this is a good thing.
When can we detect dementia? I mean, I've seen people say that dementia starts maybe in the 30s. I mean, there's brain energy uptake changes that we see early as that. Are you looking into early detection, and can we? Because obviously, if we can, intervene at a very early stage, we're going to have a much better outcome.
Yeah. So no, I'm looking at people who already developed full-blown definite dementia by the latest diagnostic criteria, depending on which disorder you're looking at specifically. So most of which would be Alzheimer's, because that's about 2/3 of dementia in the West. And so that's my interest. I guess I'm taking end stage people. So by the time I view it as decades of poor health leads to these end stage disorders, cancer, and I mean end stage. I mean malignant cancer, not like stage 4 or something like that. Definite dementia disorder like Alzheimer's or Parkinson's. Parkinson's has other things, and so on. So I'm looking at the sort of end stage and seeing if we can reverse that. It's absolutely clear to me now. It wasn't clear to me a few years ago when I graduated, because I didn't learn any of this stuff, that type 2 diabetes is fully reversible, that obesity is fully reversible. And these are also metabolic. To me, they're responses. They're not diseases or disorder themselves. They're responses indicating poor metabolic health. They're reversible. I know that because I have a number of patients with type 2 DM and so on that I have reversed, incidentally, because they also have Alzheimer's or whatever. But the exciting thing for me is to actually take the end stage disorders and see, can we improve those? And there's no discussion as to whether a person has a disorder. It's definite, it's obvious. But if you can improve those, that would be a truly wonderful thing. And I guess what I'm trying to say, Shawn, is I don't think it's ever too late. to do these strategies.
Yeah, I mean, I would echo that. I think you can always make some improvement. Now, you may not reverse things completely, but you can certainly improve quality of life. You had mentioned, I
Correct.
think, when you said you're looking at some cancer, you said ketogenic diet and beyond. Can you delve into what the and beyond stuff might be, or is that proprietary at this point?
No, no, I make no money out of any of this stuff. So, uh, yeah, we call it a metabolic therapy program, and it's basically the backbone of it is fasting, not the ketogenic diet is there obviously. So what we do with these people with glioblastoma multiforme, it's extremely aggressive, and you go on an 8-month treatment protocol where the first 6 weeks you have chemotherapy and radiotherapy combined every day, more or less, almost every day, and then you have 6 weeks where you have 5 days of chemotherapy every month. Now we know that's the standard of care, and that extends life by a few months, absolutely at most. But what we have done is design a protocol to fit in with that, where we start the person on a 5-day fast, 3 days before the chemoradiation starts. So by the time they start chemoradiation, they're 3 or 4 days fasted. So what the fasting does is it gets your ketones up super high and your glucose super low. And the whole idea is to instantly put metabolic pressure on these tumor cells, which really just consume glucose, and there's no good evidence in humans they can consume the ketones. The second thing is to force normal cells, because we focus on the cancer cells. Again, it's managing disease. We want to restore health. So we can't ignore the normal cells throughout the rest of the brain and body. So the fasting makes the normal cells hunker down into this stress-resistant mode. We know this from animal models. And in the stress-resistant mode, they become more resistant to the standard treatments, so the chemo and radiation, because remember, these things damage a lot of cells. And we know there's several randomized trials now showing that you can mitigate adverse effects of the chemo and radiation. And we're absolutely seeing that in these patients, like they're getting almost no adverse effects. So after the 5-day fast, then they start a strict ketogenic diet. Now it's a 1 or 2 meal a day ketogenic diet. So I'll have them, I've spent several years designing this program. This day you eat 1 meal. This day you eat 2. This day you eat 1. This day you eat 2. No snacks. And of course, there's virtually no processed carbs in there. And I must add, they can go vegetarian or carnivore as they want. I've designed a meal plan that allows people to do that. And some people tilt one way over the other. But as long as they're in the ketogenic state, that's the main thing to me. And then we have periodic 5-day fasts throughout the program and the timing of them is very particular. I've timed them very particularly in order to try and what I think, in my opinion, maximize pressure on the tumor cells while restoring the health of the normal cells. At the end of the day, we're looking for long-term outcomes. So it's not just about killing the cancer, which our standard therapies are quite good at. It's about keeping the body in a state that reduces the chances that the cancer cells come back, because in glioblastoma multiforme, as you know, they virtually always do. So that's it in a nutshell.
And what are the early results showing? I mean, you mentioned, standard of care, 2-month, 3-month increase in lifespan. Are you seeing that being prolonged?
It's too early to say, Shawn. So we're looking to enroll 20 patients. We've only enrolled 5. It only just started late last year. So yes, in those 5, I'm going to knock on wood here. So far, so good, but it's very early days, and I really can't tell yet. But what I can say is that all patients are doing. I was first of all not sure if they could do this protocol, because you're taking people who are eating 3 meals a day. The average BMI here is probably in the high 20s or maybe even in the low 30s, and of course, snacks and now we're automatically asking them to, okay, now you're going to do 5-day fast. You're going to eat once, maybe twice a day. There's going to be virtually no carbs there. It's a big ask, but people are amazing. I believe in people. Like, my patients continue to amaze me. So those doubts have been eradicated. At least these 5, 100% commitment. And I know they are, because they're, of course, measuring the ketones, which is a marker of the state, every day, and their glucose. And the numbers are very good. So that is encouraging. But now the question is, does this protocol work? And that will need at least a year or 2, I think, before I can get a feeling for it.
Well, I mean, if you manage to prolong them out by a year or two, then that's likely going to be better than standard care. And I don't wish you ease in recruiting patients because you don't want to wish GBM
Yeah.
on anyone. So it's kind of a tough situation. You're hoping for someone to be really sick, at the same time you'd rather not be there.
Yeah.
What about cancer cachexia? Because one of the things we often see
Yeah.
with patients cachexia, and we're doing all this fasting. Is that a problem we're concerned about with that?
Yeah. Very good question. And to be honest, I've spent a few years here getting to know the certain oncologists so they don't think I'm crazy and then I'm some idiot that comes out of nowhere telling people with cancer, advanced cancer, to fast. So I'm not worried about cancer cachexia, and I've thought about this very carefully. And I should add, these aren't the first GBM patients I've put on a similar protocol. I was given 10 sort of near end stage patients a couple of years back who were desperate for anything. And we did some of this. The cancer cachexia is basically when you're experiencing weight loss and profound inflammation where it shouldn't be in the body. And it means the cancer is running away and that person is losing their battle against cancer. It's unintentional weight loss. So the treatment is to, of course, up the nutrition. When they say nutrition, they mean tons of carbohydrate and protein and fat. So they just sort of throw it all in. Whereas I want weight loss in these patients. I tell them this is what we're looking for. Remember, most of these guys are overweight or obese. In fact, pretty much all of them are. And there's a huge difference between intentional weight loss and unintentional weight loss. If you look at cancer trials, the few cancer studies, including case reports where this has been done in the past, people who got a lot of weight loss actually had good outcomes most of the time. I would say close to all the time when it was intentional. So they went on a time-restricted ketogenic diet. So Thomas Seyfried, for example, he favors a calorie-restricted keto diet. He likes to knock down the calories and the keto diet. I don't favor that for various reasons, but he's had some pretty good outcomes. Pablo Kelly works closely with him, as you know, or reasonably closely. So that's the thing is I think cancer cachexia is indicator that you're losing. Whereas intentional weight loss, when there's no clinical symptoms of the cancer, you're not getting, say, seizures from the glioblastoma, your metabolic health markers are improving, and most of all, these people are feeling really good. They don't want to go back to the old lifestyle, and that's all very encouraging. So let's see. I mean, maybe this protocol makes them live less long, in which case that's truly unfortunate. And I will absolutely rethink my entire approach to this field. But so far, these patients are doing really well. The weight loss they've had is healthy weight loss because they're still overweight, most of them. But they're doing well in terms of quality of life, function, and so on. So let's see.
Yeah, one of the things, and I get asked about compliance on trying to get people, because we're in the business of helping people with disease as well. When they have success and they feel good, that certainly reinforces compliance. So that's a nice thing. You mentioned measuring ketones on a daily basis. Are you tracking something? There's called I'm sure you're familiar with the glucose ketone index. I think Thomas Seyfried is a fan of that.
Absolutely.
Is that something you're utilizing? And are you adjusting the diet based on that, or how do you ever have to adjust the ratio or the dietary things based on feedback like things like that?
So yes, we're absolutely measuring the glucose ketone index, or GKI, which again Dr. Seyfried created a few years back. The GKI with the fast, of course, it's very good. You want it lower, and it's definitely under 1 when they do the fast. The keto diet, it's not too far north of 1, but it is north of 1. But when you average them out, it's going to be pretty close to where we want. It might be a little bit above 1 still, because of course 20% of the program is fasting. The other 80% is this time-restricted keto diet. Look, that's a interesting question. We don't really know if an ideal GKI exists or if the variable has meaning at this point. The data is just too scant. But I think the concept is good. The theory is certainly compelling. So we are using that. And in terms of having to adjust the plan, the great thing is that because of the previous experience I've had with the Parkinson's and Alzheimer's patients and a number of other patients, the plan is pretty good now. And I know that every recipe on that plan, which I have personally eaten, that's what I eat. I eat this plan. If I don't like it, it's not on the plan. I wouldn't subject a patient to something I don't like. And so if I have something, I guarantee every meal on that plan is going to get your ketones at least above one. For a lot of people, above 2, 3, 4. It depends. Even the hardest person to get the ketones up, though, it'll get you to a 1. And it's flexible. So the plan is already pretty set through years of trial and error. And I haven't found that we've had to modify that. The only thing is sometimes a person really misses a certain meal and they ask me, they send me a recipe saying, can I have this? And usually I have to tweak it because often what's on the internet is ketogenic is not. And it's often low carb. And I'll tweak it and then we can modify it for that particular person. And that's cool. Like I got one Maori couple who they love the traditional Maori recipes, which makes sense. So there's not a lot of those in my plan because I wasn't familiar with them before. I'm learning. They're teaching me, and they sent me some recipes, and I'm like, yeah, these are actually really good. Seafood, coconut cream, go for it, and they're really enjoying it. So you can modify these things.
Yeah. What, just out of curiosity, what would be an example of a dish or two that you would that would be on your plan?
Okay, so last night I had a. It's basically I'm a personal fan. I like Mediterranean keto half the time, and the other time, I will admit, I like carnivore. So I feel best on that combination. So last night I had a salad that was half a kilogram of raw salmon in there, and I chuck in cucumber, just a few baby tomatoes, like 3 or 4. Little bit of capsicum, a lot of olive oil, like a cup of olive oil, and some balsamic vinegar and almonds. And you mix it all together. Salt and pepper, of course. It's awesome. So I've got 3 steaks in my fridge right now. I will probably have that tonight. And that'll be about a kilogram of steak. I reverse sear them. And what that means is I cook them in the oven for 45 minutes or something. And then I put them on a pan with coconut oil and I sear them in the coconut oil, flip side to side. So they got lots of coconut oil on them. And that's good. That's a meal. And as you know, I mean, both those meals, I really feel awesome the next day. And I don't get hungry in the morning anymore. I used to years ago, and I'll just power it right through to the next one. So those are 2 examples.
Do you have any issues managing electrolytes, particularly with the cancer patients with the 5-day fast, or how does that play out?
Yeah, amazing. The short answer is no. It's something I'm really worried about. But evolutionarily, we are adapted to fast. We went, every culture in the world, every person, no matter where they evolved, their ancestors went without food for a few days or something in famine. So if you didn't survive that, and preferably in an enhanced state, you wouldn't be here. So in terms of electrolytes, the only ones that I supplement, and this is on clinical evidence, I've noticed that some of the longer fasts, people were complaining of calf cramps and stuff like that. So I supplement magnesium on the fast. That's it. That's the only thing I supplement these people on in the fast, and that has helped. In terms of the keto diet, I ask them to have a multivitamin every day. Now, am I strong on that? No, I'm not. But talking to dietitians here, it's something they're very big on, and I think there's a line where you have to. You don't want to antagonize people too much, and if anyone's sort of getting a little critical of your strategies, remember I am working in a big hospital where a lot of people have very different ideas to me. So I'm checking in a multivitamin for those people. In terms of electrolytes, not a problem. So sodiums, potassiums, and calciums and so on, absolutely fine. What I do is the trick with the fasts and the keto diet is, if you want to avoid the keto flu, which is a misnomer in my opinion, or any sort of these adverse effects, it's water and salt. You got to have water and you got to have the salt. And a lot of people fall down on the salt. They don't realize you need like at least a teaspoon of salt a day to feel good on a fast, a multi-day fast. And on a keto diet, it's the same. And if you're exercising, you need more. And so I've designed just 2 very easy recipes. One's a salt sort of lemon juice recipe, and the other one's a bone broth for the fast that they have to have every day. Minimum 2 liters of water, minimum teaspoon of salt, and it's all good. So no.
Interesting that you provide a multivitamin to make your colleagues feel better.
Yeah.
I
Yeah.
think it's kind of interesting you have to do that. Um,
L-
Speaking
Well,
of
look,
which,
oh, sorry, go ahead.
I was just gonna ask you about the general climate in New Zealand. I assume it's fairly similar to the US and Canada, where this stuff is kind of considered a little bit weird, and I don't know, maybe it's more progressive over there, perhaps.
No, I think it would be the opposite, actually. They're a little bit behind here by a few years, I'd say, compared to North America and Australia. And that's a good thing. I guess, you know, most people, to be honest, they're not against. It's most people are just like, it's just so bizarre for them to contemplate. They're like, what? Like, wow, weird. And, people, there are some people who are against, and I just try to be, good to them and not antagonize people. Not all the oncologists are supportive. That's okay. They're just not part of it. There's nobody actually trying to hijack this. And then the guys that are supportive are super supportive, to the extent that one of them is actually took the plan, and he has done it himself for the last year or so. And he's dropped 35 kilograms, and he's the best shape of his life. It looks amazing. He didn't do the fast though. He just did the diet. So I'd say that because it's quite an isolated country, as you know, Shawn, you spent time here, and you're kind of isolated from a lot of that stuff. And people sort of allow you to do stuff as long as it doesn't seem too antagonistic and too crazy. And that's important to me, that I do this properly on that level. When I started here, I was all piss and vinegar. I was really pissed off at the model. The first 6 months or 12 months, I was getting in arguments with senior doctors a lot. Not just, semi-friendly, but now I realize that strategy would have had a finite lifespan. So now I'm actually, it's a journey of personal growth, not just the research. So I'm more tolerant. And if I have someone who is against what I'm doing, I actually listen to that person very carefully. I don't dismiss them. I think, okay, first of all, is that person right? They might be right. I might be doing something really bad or dumb here. And then I think about it, go, no, I think I'm right. Then I'll try and figure out where they're coming from. And quite honestly, some of the most vehement people vehemently against me a few years ago are now my biggest supporters of this. I think some people express interest in an antagonistic, maybe you've experienced this, I don't know, in an antagonistic way. And if I listen to them and just sort of go, okay, so what are you actually trying to say? Okay, well, this is why I don't agree with it. Feel free to disagree, but this is my opinion. Some of those people turn around pretty quick. It's an interesting thing, which I never really realized until I started doing this.
Well, I think, the biggest thing at the end of the day is the results are that's going to be the final arbiter of the truth. Is if you get the
Yeah.
results you think you're going to get, then it's hard to deny that. Again, there are people that will try to dismiss it as, chance, or, this person was lucky, or something. But, at the end of the day, if you consistently put up results, it's hard to deny that. And that's what I found to be the most effective, I guess, tool in the tool chest is, these are results it is what it is. And maybe I don't know the mechanism, and I'm certainly open to that, because I think it's very much, there's so much we don't know. And I'm sure as you've gone on, you found out that you know less than maybe
Yeah.
we all think we know more than we think we do, and then we figure out it's much more complicated than that.
Yeah.
Let me ask you, and so you're coming at this from a neurology perspective. I'm just trying to, I missed the beginning. Your background was it neurology, straight up as a neurologist?
Yes. I trained as a clinical neurologist, and I've, uh, yeah, I did specialize in nerve and muscle. So I did a 1-year specialty. It was not everything else you could specialize in was basically a disorder like Parkinson's or stroke or whatever. But yeah, so I'm a neurologist, but with a subspecialty in nerve and muscle, which means I know how to measure them with various techniques, nerve conduction studies, EMG, which
Yeah,
you know
sure.
about, I'm
Of
sure.
course, I used to see patients for that
Yeah,
all the time. If
you would have, you would have referred for that a lot. So yeah, that's what I'm trained in, and I like being a general clinical neurologist because it allows me to see patients with all the neurological disorders, not just focus on one, which most people subspecialize and focus on one, a very small subset. And I want to see it all and see if we can help people with various things. So I'm more about approaching these things from a therapeutic perspective rather than just learning all about the disease and how I can manage the symptoms.
Yeah, and the reason I wanted to get into that is because as we become so subspecialized in medicine, we have these pockets, and you often see that the specialists pitted against each other. One guy's fighting for this, and one person's fighting
Yeah.
for that. And I can see, one of the concerns I have, and maybe it's unfounded, but in cardiology, they want everyone's cholesterol to be as low as humanly possible. And there's some concern that may have neurological implications down the road. Does that concern you at all? Are you seeing the sort of the problems associated with that? If somebody is, you know, so focused on cholesterol that they just kind of discount everything else or nothing else matters.
Yeah, it's amazing. I mean, you hit it on the head when you say as doctors we're trained a certain way, and that's most people don't really get beyond their training. I mean, I took that 3 years out, which allowed me to just think about other things. Anyways, yes, I see that. A lot of docs are told that that they have to lower the LDL, particularly to a certain level. Now, look, if you define metabolic syndrome, if you look at what constitutes the metabolic syndrome, the LDL does not have a prominent role, except for maybe the particle size, the LDL particle size. It's the HDL and the triglycerides that constitute the definition. And those things almost always improve on fasting, keto, whatever. Now, the LDL often goes up. Sometimes it's temporary. It's a few months. It comes back down. Some people, it seems to persist. And then people, despite the fact that, say, the patients reverse their type 2 diabetes and they look and feel great, the doctors will focus on the LDL. And again, that's because that's what they're trained to do. And we won't talk about financial conflicts of interest with pharmaceutical companies and people who establish these guidelines, doctors who establish these guidelines. And I guess they fixate on this number, this biomarker. And we really don't know what LDL is doing in atherosclerosis. The concern is that this high LDL is somehow causing atherosclerosis, which is the main thing behind heart attacks and some strokes. But look, we don't know what LDL is doing. In my opinion, if you look at the evidence properly, it's an intermediate step, the LDL accumulation in the blood and in the arterial wall in the atherosclerotic process. Now, is it contributing to it? Maybe. Is it a bystander? Maybe. Is it protective? Possibly. And what we do is we get insufficient data. We saw this with the COVID-19 pandemic, if you want to talk about that or whatever. You get insufficient data, you make a reactive decision that this is the way it's going to be, and then you enforce that decision for years to come. And then it becomes a paradigm, and then it's very hard to dislodge that. So at this moment in time, we're all about the LDL. We focus on that more than the fact that diabetes is getting reversed or HDL is going up, which is good, triglycerides going down, which is good. And yeah, I see that all the time. And I don't like that kind of thinking where you just do something because everyone else is doing it. Conformity. If there's one thing I'm very against, it's conformity. I like people. When people think for themselves, they often, they do good decisions if they're truly thinking for themselves. And I see that, and it's just groupthink.
I think I recently saw a headline, and maybe you may know this is your area, but I think there was a recent analysis looking at Alzheimer's or dementia in general and lipids, and they saw that there was a high correlation between high triglycerides, low HDL, and LDL didn't seem to have much of an impact on that. And yet the headline was, lipids cause Alzheimer's disease. If you don't read past that, the assumption is you're going to think high dietary cholesterol is a problem, when in fact the opposite seemed to be the case, where high HDL was protective. And we know as HDL rises, very often we see a concomitant rise in LDL. Like I said, on a ketogenic diet, we often see HDL improve, but LDL goes up with that. But
Yeah.
was that correct in that? Did you see that recent paper, or did you see the headline on that? I don't know if you did or not.
No, I didn't see that headline. To be honest, I try to stay away from media articles. If you want my honest opinion, Shawn, a lot of these studies that are done are correlative only, observational only, and people have this tendency, it's human nature, to draw causative conclusions. I'm sure you've encountered this. So they'll show an association between, say, high protein intake and some disorder, and then they'll automatically, the conclusion in the paper, which is bad for a scientist to do, is that, the high protein somehow caused this disorder. You see this all the time. And then the media will take it a step further often and have a big headline. So I try to avoid those things. I'd rather look at interventional trials where you had two groups, and one treatment was started in one group and not the other, and then, oh wow, this group improved and that didn't. That's far more powerful because that shows you causation. You can have a lot of interesting correlations. For example, people with Parkinson's smoke far fewer cigarettes than people without. So does that mean I can prescribe cigarettes to my Parkinson's patients? No, I don't think so. So, that's the problem I have there. So yeah, I didn't see that study. I'm sorry, but I'm not surprised at what you expressed, that's how it was interpreted by the media.
Yeah, it was kind of interesting. I had a guest on the other day who actually was the principal author on a study that was misinterpreted by the media, and he was basically saying the same thing. He did a study on higher protein and testosterone and cortisol levels, and the media interpreted that saying that high protein diets, or no, they interpreted saying that meat eating leads to infertility. And there was nowhere in the paper was that discussed at all. And that was a conclusion on it. And he came on and said, this is just ridiculous. And so I agree, these correlative studies, these observational studies are almost less than worthless in many cases. I mean, you can generate hypotheses, but they're used to often drive a narrative in many cases, unfortunately.
Yeah, one thing they do is, I'm sorry to interrupt, is they can cause more confusion. And with the era we're in, with the internet and so many different people telling everyone, this diet's better, that diet's better, this is how you should live your life, that's how you should live your life, it's confusing, isn't it? And so people, I think what I find with my patients is they get confused. They don't know what they should do. And if we could actually do good data, good research, and find out, okay, this is better than this for you, that would be awesome. And then you clear up confusion. So I think confusion with all these different opinions is a huge thing. And these correlative observational studies add to that. There is a good thing in all of them. I don't dismiss them all, but I agree that they tend to cause more confusion than anything. And it can put you behind by many years because people hold on to this as a causative link when it's not.
The other thing I think people get confused, they don't really know what to measure anymore. And so they get hung up in some particular biomarker and they're like,
Yep.
am I actually healthier? And how do you define that? And I think as simple as it sounds, it's like, how do you feel? How do you perform? How do you look? How are your systems working? Does your digestion work? Do your joints hurt? On and on and on. Stuff that's hard to easily objectively measure, but it's much more meaningful for the patient themselves. Let me ask, because you alluded to this, I'm in the United States, you're in New Zealand. Both of us are in countries where it's the only place in the world where they allow drug manufacturers to advertise direct to the consumer, which is just an interesting thing. But New Zealand, the response to COVID was fairly rigid and sort of, I've seen recently where I think the Supreme Court there said some of these things are now considered not legal. But did you find that, was everybody kind of marching the same beat there? Was there some dissent in the way it was being handled? My biggest frustration is we did zero to discuss improving metabolic health, or just try not to eat junk food while it's going on or something. Did we see that?
Yeah, I saw. A lot of people conformed, but there is a significant vocal group from what I've seen that did not conform. And look, I'm not a lot of the anti-vax arguments were a bit over the top, but as well. So I'm not picking a side here, but in terms of what you said, so there were two problems with I don't want to get hung up on C19, but one problem with C19 is, for example, we didn't look at it objectively and scientifically and assess the data properly from the get-go. So we had countries with different strategies. So Sweden had a different strategy, Belarus had a different strategy, and countries that didn't do what most countries did were automatically attacked in a sort of emotional way by the media, like really attacked. The proper scientific approach there, the rational approach, would have been to, okay, let's see what happens to Sweden, Belarus, and other places, different states in the United States that have a different slant on lockdowns and so on. Let's look at the data in 1, 2, 3, 4, 5 months and see who was right, who was better. There was very little of that, if any. And a lot of articles were just coming out biased with faulty conclusions, saying in support of this certain strategy that most people adopted. The second thing is exactly what you said. So here we have vaccine mandates and we have lockdown mandates and everything. And I'm not going to argue whether that was right or not, although I do have an opinion. But the elephant in the room is that the people getting really sick from this, we got about 50 in the hospital now. They're people with a chronic lifestyle related disorder. They have very poor metabolic health. Most people actually in the West have poor metabolic health, but these are people with very poor metabolic health. So, it's interesting that that was not discussed, as in the best way to protect yourself from COVID might not be this vaccine. It might be to improve your metabolic health. And then you become a much lower risk of getting it. In my opinion, if you have optimal metabolic health, a lot of people think they do, but they do not, then you really shouldn't get symptomatic from COVID-19. I think that's a huge statement to make, and I'm not going to I'm not going to linger on it, but really, if you're metabolically healthy, this is a virus that should not put you in hospital.
Yeah, it's interesting. I've interviewed three physicians. You're the third physician in the last week. One was working at the busiest. He was a cardiac anesthesiologist doing COVID patients in one of the busiest hospitals in London. Another one's in the medical center in Houston, Texas. And both of them said they literally did not see a single metabolically healthy person in the ICU. They were all either obese or diabetic or had significant comorbidities. And so clearly that's not, and that doesn't surprise you. It doesn't surprise me. We all know that. Everybody's been in medicine knows every time there's something that goes on, these are the people that always get sick. And
why we
don't we prioritize that in different response to other folks?
Yeah, there are various reasons. It's a shame, isn't it? Because I think a lot of people would do the right thing if they knew, but they're just not told because the mainstream media has a different agenda or whatever. But yeah, like, first of all, I used to think it was all about the drug companies and that they push in the products. It's in their interest to keep us unhealthy because we keep going back consuming. And I do still think that to an extent, but actually what I realize now, it's mainly conformity is the problem. So like in medical school, I'm sure you have colleagues, as I do, you graduate with, they never really get past their training. You get taught a certain thing and then you finish as a senior medical officer or consultant or whatever, and you think that you are an expert in a sense, of course, but there's so much more to learn, isn't there? Like, if you start thinking you're the bee's knees at the age of 35 or 40 because you've just finished your arduous training program. I mean, they are arduous. They're many years of work and sacrifice, but I mean, it's really just the beginning, and you got to keep an open mind and keep working and listening to your patients in particular, because they'll tell you a lot of good things if you listen about how to improve yourself. And I guess, a lot of these guys they get stuck in the medical mode. Medications are the way, or just surgery might be the way. And they never really look beyond and at the potential power of some of these other approaches that could make people and humanity in general, I think, better.
Yeah, absolutely. And I think, I've discovered that, and I was the same way for the most of my career. I was just like, people would tell me that, eating gluten would make their knees hurt. And I thought they were crazy. I mean, I literally just pushed them out of hand because I thought I didn't learn about that. There was nothing in my textbook that said that. So you must be a crazy person. And then it really comes through, actually taking the time and listening. And unfortunately, much of medicine is now, it's such a high paced, rapid turnover. I don't know, it's like in New Zealand, but in the United States where, 15 minutes is a luxury. And so I often had 3 or 4 minutes with patients and that's all I had. And it's kind of like, you can't really get into lifestyle stuff. You can barely get time to type in the computer, which is another issue. What, let me just ask you, because we've got a few minutes remaining, but you said you like to look at some other things. And so, I mean, most of us have heard of dementia and Parkinson's disease. And what other things out there from a neurologic standpoint are you seeing diet has some efficacy in?
Okay. There's still a lot of related to cancer and neurodegeneration. I think those are the two big categories I'm focusing on. Cancer more so now, neurodegeneration in the past. So I just had a patient with Huntington's disease who did a 1 year, it was a time restricted ketogenic diet, no 5-day fast. I don't, if you have anyone with Huntington's, but they tend to be a very low body mass index. And so this guy was like a 19.8. And he was deteriorating quickly, very, quite advanced Huntington's. His fiance was looking, he had a fiance, but they were looking at care facility options and so on. And they came to the clinic and they were just desperate. They knew what we did and they were just desperate. And I was like, I don't want to start this. This guy has a low BMI. He's really thin. He's quite advanced. I mean, I don't want to, this will be the first person in the world, to my knowledge, that anyone will do this on with Huntington's. And I don't want to start this on a sinking ship, so to say, but we did because they were desperate. So let's give it a crack. And he's done remarkably well. So that paper's just been submitted. We'll see what happens in a few months when it's published. Other conditions, there are certain muscle disorders like muscular dystrophies. I've got one young girl doing that, experiencing improvement. I've got a patient with motor neuron disease that's been doing this now for 4 months. So that is one I've always been a bit scared of, because it's like glioblastoma. It leads to death very quickly. So that's a condition I'm looking at. And yeah, those are just some of the other ones.
Yeah, it's interesting, and I don't know how much this falls under the purview of neurology versus maybe psychiatry, but I had someone with Tourette's syndrome, and they were vegan, grew up as a vegan, developed Tourette's syndrome.
Oh, okay, yeah.
As they often do, spent 4 or 5 years with vocal tics and motor tics, and had all the diagnosis, and ended up on a carnivore diet and gone. Been gone for 4 years now, and so that's something that I think it's just interesting. You're seeing all these things. I had someone with Ehlers-Danlos syndrome, which is a genetic connective tissue disorder. Which I don't know how much familiarity you have with that, but it's
I know it well.
But and they were dislocating their joint multiple times a day. We put them on diet, and that stopped, which I thought was just it kind of blew my mind.
Interesting.
You kind of find these crazy things that are happening there. I have someone in the group that has Parkinson's, and they want to ask a question. Patty, go ahead and type your question, and we'll try to answer it if you don't mind. Let's see if she can type it, or maybe I don't know, maybe I can unmute her. So I don't know. Let's see if I can do that real quick. Find her. I don't know if you'd rather just mute it. Patty, why don't you go ahead and unmute yourself and ask it yourself if you'd rather do it that way.
Thank you. That's here. I'll put the camera on too. Thank you. That's easier than typing. Oops. So yeah, I've got hemi-Parkinsonism, hemiatrophy syndrome apparently, and I've been doing keto and carnivore for several years. Carnivore starting in January 2018, and I'm getting good results health-wise, but not with the tremor and rigidity. And I'm wondering if perhaps eating a high protein diet is not working as well for me as if I were eating a high fat diet.
Yeah, very good question, Patty. So first of all, well done for trying to take control of your health. I got to ask, are you taking medication, levodopa medication? No. Okay. So the main problem with Parkinson's and high protein is it's just if you eat the protein around the medication, because the protein amino acids compete with the levodopa for absorption. So I ask people to, if they're on medication, to definitely eat 1 hour before or after the food, a full hour at least, and only take the medication with water. Now, if you just have a Parkinsonian condition and you're not on any medication, does the high protein somehow not beneficial? I don't know. I couldn't even really theorize on that. I would probably say you've experienced some improvements. I did notice in our Parkinson's trial the movements, the tremor, and the slowness, and that they improved less than the non-motor symptoms that I described: the sleep problems, the mood problems, and there's other things, urinary dysfunction and cognition and stuff. So all that stuff improved more than the movements, although the movements did improve. So it's not surprising to me that your movements haven't really shown a great benefit. I would only say maybe chuck in a bit of fasting, maybe do a 2 meal a day strategy and 22 hours of fasting, and eat as much carnivore or keto as you want during that time. And maybe that could improve you more.
Okay. Thank you.
Welcome.
Yeah, thanks for responding. Thank you, Patty, for asking that question. This brings us to an hour, and I usually try to keep these things to an hour. So,
Yeah.
Dr. Phillips, tell us if somebody wanted to find out more about what you're doing, about your research. Maybe there are patients looking for, I don't know, do you do online consultations, or how do you typically run your practice?
Oh, yeah, so I do have we have a website that a patient started for me actually, and now I just build on it. So metabolicneurologist.com. If you go there, you'll see basically all our work, all the videos, podcasts, and so on. I haven't done too many at this point in time, but they are accumulating. It's all there, and there's actually a metabolic strategy plan. It's basically the time restricted keto diet, 2 meals a day that people can download for free. I don't copyright or anything. And my email address is there if you want to get a hold of me. Do I do online consults? I'm trying not to, because I'm full-time clinical research teaching. I do a lot of teaching in the hospital too, and it's basically I don't have enough time. But I'm seeing that the demand is actually increasing. So at some point, I may start doing online consults. I don't want to charge money for anything because various reasons, but at some point, maybe I'll ask for donations or something. I do the occasional online consult for someone who's truly desperate and is someone I feel like I could really help. So yes, I do them, but I don't do them as a rule because time is very much a limiting factor right now.
And do you have any? Are you a social media person? Or you try to avoid that? I mean, I unfortunately.
No, no, Shawn. I joined just like late last December last year or something on Twitter. So the answer is I'm not a social media person. I check it maybe once a week, but I joined. I started following you a month ago after I knew we were going to do this talk, just to see some of the stuff you put out. And so yeah, I'm on Twitter. Feel free to check it out. But I have a very modest following. It only just started, and I put up stuff about our research, once a week or something. But I'm not on there too much.
And what is that? What is your handle on Twitter, if you even know it?
Oh,
you know it.
No, I think it's at Dr. MCL Phillips. If you go to metabolicneurologist.com, that website, the Twitter link is there. I know I did that right. So.
All right, I'm going to go look that up and give you a follow. So anyway, thank you, Dr. Phillips, for being here, and keep up the wonderful work. And if you get some more, if you got another study that you guys get done or you want to talk about, feel free to come back. I'm happy to share the word. And because I think this is stuff that's changing a lot of people's lives, and we need to get that message out there. So thank you.
Awesome. I have one question for you, Shawn.
Sure.
Do you think you'll ever come back to the Waikato and visit?
I would love to. I mean, like I said, I would love to get down there. Probably maybe Australia, New Zealand, because I never got to New Zealand. I never got to Australia, so I might make a trip down there. Probably maybe the next three years or so would be my guess on the timing. Wait till the travel opens up a little bit. It's not so.
Yeah. Well, if you do, let me know. We'll go out for some steaks.
Sounds good. Thank you very much.
Right. Take care.
So take care, guys. Bye-bye, everybody. See you guys tomorrow.